Picture this. A patient with diabetes sits in your chair. You check their visual acuity, and it's a perfect 6/6. They have absolutely no symptoms. You're looking into their eye, and everything seems completely normal, except for one tiny red dot right at the back of the eye. Well, that tiny red dot could actually be the very first sign of a disease that remains one of the leading causes of preventable blindness worldwide. Welcome to the explainer that turns textbook knowledge into clinical pattern recognition. For all of you optometry students and clinicians out there, today we're answering one absolutely crucial question. If you see a diabetic patient tomorrow, are you going to know exactly what to look for and exactly when to refer them?
Okay, let's dive straight into this scenario because honestly, this is the exact moment your clinical decision-making is put to the test. To really understand what's happening, I want you to imagine the retinal circulation as this old, aging pipe network. Over time, diabetes gradually weakens the walls of those capillary pipes, causing microscopic leaks, blockages, and eventually the growth of highly dangerous new vessels. But here's the tricky part. Early on, the patient feels absolutely nothing. The threat is completely silent. It's solely up to you to spot it.
And that leads to the critical takeaway from our clinical guidelines. It's a foundational rule for your practice. Every single diabetic patient requires regular screening. We aren't just doing a routine check for a change in refractive error here. We are specifically hunting to catch the silent threat before it progresses to a proliferative, sight-threatening stage.
All right, here is our clinical pathway for today's explainer. We'll start with Section 1, the patient history. Then move to Section 2, non-proliferative signs. Section 3, proliferative signs. Section 4, the complications. And wrap up with Section 5, the referral framework.
Starting us off, Section 1, the patient history.
So, before you even turn on the slit lamp, the patient is already giving you clues. Your history taking needs to be razor sharp here. You want to establish their type of diabetes and the duration of the disease right off the bat, because duration is literally one of the strongest risk factors you'll face. And notice how we only ask about sudden versus gradual onset if they actually report having symptoms. This kind of targeted approach saves you precious clinic time and zeroes right in on the pathology.
This beautifully illustrates how we can mentally map subjective complaints straight to objective findings. If a patient sits down and says, my vision has been blurry lately, your mind should instantly jump to fluid accumulation and diabetic macular edema. But if they say, I'm suddenly seeing these black cobwebs, huge red flag. That points right to proliferative diabetic retinopathy. See, you're forming a diagnosis before the room lights even go off.
Moving along to Section 2, non-proliferative signs. Let's look at those early clinical indicators.
Now we move to the objective exam. Look really closely at those tiny red dots on the image. Those are microaneurysms, which is usually the very first clinically visible sign. A great way to remember this is to think of them as little balloons forming on weakened blood vessels. You'll also spot bright yellowish-white hard exudates. Here's a memory trick for you. Hard exudates are essentially the dried-up lipid residue left behind after a blood vessel leaks. We really must train our eyes to spot these patterns immediately.
Let's define this stage clearly. Non-proliferative diabetic retinopathy is marked by microaneurysms, hard exudates, cotton wool spots, which indicate ischemia, and blot or flame hemorrhages. A quick exam-focused tip for you here. Do not confuse deeper blot hemorrhages with microaneurysms. And please remember, at this non-proliferative stage, patients are almost always completely asymptomatic. Their vision is perfectly fine, which is exactly why your screening is paramount.
Now for Section 3, proliferative signs. This is the sight-threatening stage.
This is where the disease shifts from something we just monitor into a true sight-threatening emergency. Basically, when the retina gets starved of oxygen, it panics. It tries to grow new blood vessels to compensate. Your crucial skill as a clinician is distinguishing normal vessels from these fine, fragile, tangled networks of neovascularization. On the left here, you see new vessels growing directly on the optic disc. And on the right, you've got neovascularization growing elsewhere on the retina.
So the defining rule here is simple math. Proliferative diabetic retinopathy includes all the non-proliferative signs we just talked about, plus neovascularization. And listen, these aren't healthy blood vessels. They have zero structural integrity. They're just a fragile, desperate response to ischemia, and they drastically increase the risk of catastrophic bleeding.
Which brings us to Section 4, the complications. What happens when these new vessels fail?
Because when those fragile vessels inevitably fail, we hit the absolute most dangerous phase for our patient's vision. And this brings us right back to that vital history question we covered earlier. Have you noticed new floaters? If a patient suddenly reports this, often describing it like a swarm of black cobwebs appearing out of nowhere, alarm bells should absolutely be ringing in your head.
So, why the floaters? Well, blood from those fragile new vessels leaks directly into the vitreous media, causing a vitreous hemorrhage. On top of that, the fibrous tissue that grows right alongside these new vessels can start to contract over time. This physically pulls on the retina, creating an elevated pale area in the fundus, which is the classic clinical sign of a tractional retinal detachment.
Take a look at this. This image perfectly captures the devastating endpoint we are desperately trying to prevent. You can clearly see a detached retina right alongside a retinal tear. This is exactly why early detection isn't just about ticking boxes in a chart. It is literally about saving a person's sight from permanent, irreversible damage.
And finally, Section 5, the referral framework. Let's build your action plan.
This might just be the most important part of the whole explainer. You've spotted the signs, you know what they mean, but what actually needs referring and how urgently? Making the correct referral decision based on your clinical findings is the ultimate test of an optometrist's competence. Let's break this down into a super simple traffic light framework.
Seriously, you might want to screenshot this matrix. Think in traffic lights. Red means an urgent 1-week referral. This is strictly for proliferative disease with that dangerous neovascularization. Yellow means a soon or 1-month timeline, usually for specific non-proliferative cases depending on how they're being treated. And green means routine, applying to your mild or moderate non-proliferative cases that have no symptoms.
So your critical pathway looks like this. Step 1, identify the proliferative neovascularization. Step 2, refer urgently within 1 week. Step 3, the patient receives targeted laser treatment. And a great tip here, to reassure your patient, explain that this timely laser treatment essentially cauterizes and halts those dangerous new vessels right in their tracks before they can cause a massive hemorrhage.
Let's lock in these exam-focused takeaways with a quick, rapid-fire review so you never miss a finding. See a single microaneurysm? Monitor it. They're usually asymptomatic. Patient reports sudden blurry vision? Think macular edema. Spot new vessels on the disc? That is proliferative DR, meaning an urgent 1-week referral. And one final pro tip for the anterior eye. Always check the iris for rubeosis before you dilate and measure IOP to assess their risk for secondary glaucoma.
So think about your very next clinic day. When that diabetic patient sits down in your chair, will you spot those tiny red dots before they threaten a patient's sight? And if they return a year later complaining of sudden black cobwebs, are you going to be completely ready to pull the trigger on that 1-week urgent referral? The pattern is right there in the fundus. You just have to know how to read it. Keep studying, keep looking closely, and I'll see you in the next explainer.